Hi, me again. So I'm Anjni Joyner. I think you guys have probably said it on another lecture of mine, but I work at Duke University Hospital. I'm also medical director for our local EMS system, and I have a joint appointment with Duke NUS, which is the Duke National University of Singapore, which is going to be part of the work that I'm talking about today in Southeast Asia. So some disclosures. This work was funded by your neighbors to the west, the Lairdale Foundation. Part of it was also funded by the Stryker Corporation and the Temasek Foundation in Singapore. This is our project team. It's quite a large team, mostly with Duke University and Duke NUS in Singapore, but we also have partners across Southeast Asia and Thailand, Malaysia, Indonesia, Philippines. And so we also make a concerted effort to include learners into our program. So we have a lot of medical students from both Duke University and Duke NUS, as well as a medical student from Thailand working with us. So to give a little bit of background as to what I'm going to be talking about today, I wanted you to shift gears a little bit and think about low and middle income countries and kind of the overall global burden of emergency conditions. So globally, emergency conditions contribute pretty substantially to death and disability, disability-adjusted life years, or DALYs. This was a recent study that looked at the top 15 causes of death and disability-adjusted life years and categorized them by acuity. And so they found that all of them were Category 1 or Category 2 conditions. And so Category 1 are those conditions that must be addressed within hours to days, and Category 2 are conditions that are commonly associated with acute decompensations. So we know this is a problem. People are dying from emergency conditions on a daily basis. Where is this primarily happening? So as you would expect, and as you've probably learned before, a lot of this burden of disease is in Africa, in parts of Africa where emergency care is severely underdeveloped. But Southeast Asia also shares a pretty significant burden of disease and disability-adjusted life years from emergency conditions. Historically, the focus has been on communicable diseases in the global health context, but now we're starting to look more at non-communicable diseases as well as trauma and addressing those conditions as well. This is a framework from the WHO kind of outlining emergency care, and this is essentially highlighting the importance of having a robust emergency care system. Over 50% of deaths in low and middle income countries can be prevented by expanding emergency care and strengthening existing emergency care systems. And much of the system is actually pre-hospital. So there is a portion of facility-based care, but it's really the pre-hospital care and the public health systems that are going to identify patients, ensure rapid and timely treatment, and then ensuring that they are being transported to appropriate locations. So one of the most significant barriers to improving these systems in low and middle income countries is a lack of clear standards to guide development for EMS systems. Many of the existing tools and measures are really focused more towards high-income settings or developed EMS systems. And so there doesn't really exist a tool for kind of guiding these newer EMS systems and their development and growth. In Southeast Asia specifically, the majority of emergency systems, or EMS systems rather, are in their very early stages of development and therefore could benefit from a set of standards. This is a framework of survival from out-of-hospital cardiac arrest that I'm sure you've seen some version of in your career as an emergency physician. And this is actually from the Global Resuscitation Academy and kind of expands upon this well-known framework. This inner circle represents attributes of an EMS agency for which that EMS agency has somewhat control over. The outer circle are those aspects of the system that are out of the control of the EMS system. But this speaks to kind of the broader context for which we have to consider change and improvement when approaching improving out-of-hospital cardiac arrest. Oops. So, but we know that time-dependent and emergency conditions are not just limited to out-of-hospital cardiac arrest. It applies to numerous other types of conditions, including perinatal emergencies, infectious disease, trauma, et cetera. So you can actually apply this framework to other emergency conditions as well. So with this in mind, we set to develop what we call the Prehospital Emergency Care System Evaluation Tool, or PECSET. And this was modeled after the Global Resuscitation Alliance 10 Steps to Improve Cardiac Arrest Survival, but is meant to look at the broader context of emergency conditions outside of out-of-hospital cardiac arrest. The purpose of this toolkit is to allow EMS systems to measure their performance, identify areas for improvement, to monitor their progress over time, and to guide priorities for future development. So these were the primary objectives when we were looking at developing this. So one is the long-term goal is to improve morbidity and mortality from time-sensitive conditions by improving the care delivery of pre-hospital emergency care systems. Our focus is on low-resource settings and developing pre-hospital systems. And we wanted to do this through introducing quality and performance measures. So this is a very busy slide. You don't have to read all of this, but this is just to say that we did not want to reinvent the wheel. There's a lot of work being done already on pre-hospital system development and emergency care system development, and we just wanted to make sure that our project aligned with these ongoing efforts. And so we looked to the Global Resuscitation Alliance, the Acute Care Action Network, which is primarily run with AFSEM and WHO, and wanted to make sure that what we were doing kind of fell into line with these other larger organizations. So to develop this tool, this was a multi-step process. We started with a survey of emergency care leadership and EMS leadership across Southeast Asia. We did a few focus group discussions with a smaller pool of EMS leadership. And then we performed a scoping review to look at different quality measures in EMS. Through this, we performed a thematic analysis and synthesis of our results, which resulted in 27 elements. And these elements are kind of defined as the broad building blocks of an EMS system. And from these 27 elements were the starting point for a modified Delphi process. So we wanted to do a consensus process with EMS leadership in Southeast Asia. So we recruited 32 participants from EMS systems in South and Southeast Asia. We had 12 countries represented in this Delphi process. And we started with a round one of e-voting. And so participants were, we presented each of those 27 elements, and each participant voted on a Likert scale, whether they strongly disagreed all the way to strongly agreed with the inclusion of that element in this final tool. And then we also included an aspect of importance and feasibility, because this is really important. If it's not feasible for them to put this type of change or building block into place, or even to measure the data, then it's not really going to be effective. And so we wanted to ensure that there was a component of feasibility included in this. So the next steps with this project, from after our e-voting round, we had 3 more in-person rounds in Singapore, where we had all of our stakeholders in person to kind of go through all of the different elements. And I forgot to mention, in round 1, there were also some additional suggestions for elements. So we had people suggest a total of 5 more elements. So the in-person voting rounds, we took the discussions from round 1. We had people discuss the results, and then we did a 5-point Likert scale, again, including the feasibility and importance. And then, again, discussion. Round 3 of voting was a yes or no for inclusion of the elements. Should this element be included or no? And then round 4 was another yes or no inclusion of the elements after discussion. And then this is what we came up at the end. For those elements that had greater than 85% agreement to include, those were our core elements. For 75 to 85%, those were intermediate elements, and less than 75 were advanced. And this was kind of interesting. We kind of veered a little bit from our original plan because the participants, the 32 participants and they were all representatives from Southeast Asia, they wanted every single element included. We were going to cut some, but they were like, nope, we want them all included. So we came up with a compromise to have this tiered system. And so the core elements, I think, are really interesting. So these are our results. These are the core elements that had greater than 85% agreement. And these are no particular order, but I think probably these are pretty similar to what you expect in your system, what I expect in my system. So dispatch assisted instructions, standardized training programs for first responders. I think I just have some examples highlighted here. Availability of an access number for medical emergencies. This is a really common problem, particularly in Africa and some parts of Southeast Asia. They don't have a centralized number for emergencies. They may have 12 different numbers because there's 12 different ambulance agencies working in that area. And so it's hard for patients to remember which number they're supposed to call. These are the intermediate elements and the advanced systems elements. So just a couple of other elements to highlight here. Scope of practice defined at a national and regional level. I see that there are some commonalities here with that, and I think there are probably some similar challenges that they are facing as well. Protocols for mass casualty incidents and disaster management. For advanced systems, formal interfacility transfer system protocols, monitoring quality assurance, and air transport infrastructure. We found this one really interesting because this is always a hot topic in the global health EMS community, because they're like, well, why? If you should be focusing on ground transport, helicopter transport is so expensive. What role does it play? But if you think about the countries that we were working with on this project, Indonesia, Philippines, they have very mountainous areas. They also have multiple islands. And so air transport actually does make sense in these countries. And many of them are now middle income, so they actually have better finances to be able to purchase helicopters. So this was something that they felt pretty strongly about that was needed. So to make things even more complicated, each of these 32 elements also has a number of indicators, and we are next week, we are going to finalize all of the indicators for these 12 elements. So these are kind of our simple yes or no measures as to whether that element is being fulfilled or whether that element is implemented. So for example, essential patient care record documentation, medical record management. Are there standardized pre-hospital documents, yes or no? Is there monitoring for completion of essential information and data fields in the EMS documents? Really simple yes or no questions. We want this to be a usable tool for people. So we started to roll this tool out in 2023, and by a rollout, I won't say that it was an implementation, it was more of an introduction of the tool to our partners. These rollouts were paired with resuscitation academies in all of these countries, which is where the Stryker funding came in because they paid for a lot of these resuscitation academies. So we had a chance to meet a lot of pre-hospital personnel. I think I only went to one of these. But our team was able to have someone at every single resuscitation academy event to describe the tool, to get input on it, and then to administer surveys. So these are some of the results from the survey, and I will say that we did have the participants from the resuscitation academies complete surveys after they completed the tool. We had them kind of use a Qualtrics survey to fill out the tool with the 32 elements, just to kind of see how their system was functioning. So overall, people really seemed to be in favor of this tool. Most of them said that they were either likely or extremely likely to use the elements, and as well as to share the elements with other medical directors of other EMS systems. They expressed confidence in being able to apply the tool to their area of work, as well as confidence that the tool would actually impact patient outcomes in their region. And then most of them agreed that they would plan to use the tool as a part of their work. We looked at the top 2 elements that each system wanted to focus on, and there was a lot of variation, but layperson public awareness and education programs was selected by all 5 of the countries that we surveyed. And then the second most common was dispatch-assisted instructions like CPR and first aid. And then when we looked at implementation status, so how many of these countries were actually implementing tools, it's a lot of variation. So Thailand seems to be doing pretty well, but Philippines is pretty far behind. And this was calculated by assigning a value of 0 to 1. And if they responded that they had implemented this in their country, then that was a 1. If there was a partial implementation, it was a 0.5. And if there was no implementation, it was a 0. So we have also been working on a web-based application to kind of track the tool, allow users to log in and view their progress over time and to share with other stakeholders within their agency. And this was Sing Health in Singapore. They've donated their time to help create this platform, which has been really wonderful. And this is kind of an overview of what this looks like. This is still in progress, but hopefully this will be completed in the next few months. And we are rolling out our pilot study next month. I'll be in Bangkok to start the first pilot session for this program. So we were fortunate enough to receive a second round of funding from the Laerdal Foundation, and we'll be piloting PECSET in 2 EMS systems in Bangkok, and actually we've added a third in Chiang Mai since I've put this together. So these is just a brief overview of the 2 systems. Dr. Sata Riapan is our primary partner in Thailand, and he is wonderful to work with. The aims for this pilot study, so aim 1, it's planning on doing a qualitative portion. We want to identify the barriers and facilitators to the use and adoption of the PECSET tool using qualitative interviews with local stakeholders. Our aim 2 is we aim to pilot test the mobile application of the tool within now 3 PEC systems, pre-hospital emergency care systems in Thailand, and examine clinical outcomes. And aim 3, we want to evaluate the implementation using the RE-AIM framework. So just a little bit more detail on aim 1, qualitative interviews. We are planning on interviewing EMS administrators, hospital staff, medical directors, quality management personnel, as well as field staff. And aim 2, we are going to implement the tool and follow these agencies for 2 years, as well as and track their data through surveys as well as clinical outcomes. And the clinical outcomes that we're using are through the PEROS registry. So this is a cardiac arrest registry that all of the systems that we'll be working with in Thailand are using to track their out-of-hospital cardiac arrest data. And so this gives us a really nice way to be able to track outcomes. And then finally for aim 3, we're applying the RE-AIM framework to see how often the tool is used with reach, effectiveness, looking at internal validity, adoption, updates to the system, fidelity and use, and surveys, and then maintenance was long-term use over 3 years. And this is just a little bit more detail. This is, I won't go into this amount of detail. And this is just kind of some of the data sources that we are using for the RE-AIM framework. So we're using a combination of existing health data, surveys, interviews, and metadata from the web application. So parallel processes, we feel really strongly about engaging and strengthening local research capacity. So we are hiring local research assistants on the ground in Thailand who can administer the surveys, translate, and participate in the research project. And then we are continuing to mentor learners in both Thailand as well as the US and Singapore throughout this project. So next steps, we hope to disseminate the tool to other countries within Southeast Asia. And we are working with some Germans, interestingly, who want to pilot the tool in parts of Africa, where they have some longstanding connections. So, and there's a lot of interest from the Global Resuscitation Alliance in expanding into Africa, so that might be in the future. And that is all I have. Thank you.
Thank you. That was a lot of information.
It was a lot. Sorry, guys.
I was just wondering if I understood correctly, because I was thinking, is there any like, I don't know, morbidity or mortality outcome like down the line when they've been through the hospital as well? Because I know in Norway, for instance, they had a development of the EMS system and it became very good, but every time they left the patient with the emergency department, was still run by interns and residents, and they took another 4 hours before they did anything. So really the improvement they did pre-hospitally didn't really reflect the patient outcome eventually. So I was wondering, like, the chain, how do you assess for that?
We should be able to get that data from the PEROS registry, at least for out-of-hospital cardiac arrest. For other conditions, that data is more challenging to obtain from the hospital. And a lot of that has to do with ownership of the data, which is a problem that we've kind of learned more about in many of these countries. Once the patient is handed over to the hospital, the EMS records go with the patient, and then they belong to the hospital, and the EMS agency can't get the data back without asking for permission and going through multiple levels of red tape. So it is a challenge that we've identified and are trying to kind of work around on how EMS can have better control over their own data, and outcome data, which is very important.
I just have a general question about mortality. If someone survives, then they will die later. So you can never stop the mortality of people. Instead, you can see how long they live. So it's the normally some time is the last time when you come to the hospital. If you're not allowed to die at home.
Yeah, that's an interesting point. So usually for out-of-hospital cardiac arrest, we use different markers of survival. So survival to hospital admission, and then 30-day survival. So there are kind of discrete time points that we use to measure mortality, and then after a certain period, we just kind of stop measuring because
I wonder if it's not a better measurement to see if the life expectancy increases.
Yeah, I think from a population health perspective, that makes a lot of sense. But I think there are too many factors that go into long-term survival for us to gauge whether or not the EMS system had any impact on that. Yeah.
No. We need the microphone? Yes. We're recording.
Yeah, hi. It's actually, unfortunately, I missed the first 5 minutes, but it's a very interesting topic because it's partly something that a research project we have already been starting up in Karolinska Institute with similar trajectory. And my question was really, you've only been looking at countries that are, so to say, in stable, peaceful areas, or
yes.
Are you planning to expand this to areas which is maybe seeing more political political conflict or even armed conflict or such?
I mean, there's no specific plans to focus on those specific areas, but I think the next steps are expansion, and the most sensible place to expand into outside of Southeast Asia is Africa, because Africa is incredibly underdeveloped with both emergency medicine and EMS. And there's a lot of interest from larger organizations in working in this space. So I think inherently that is going to include some areas of conflict, but there's not a concerted effort by us to target those locations. But it's a good point. I mean, it's very different. It's very different to focus on areas where there's large refugee populations and fluctuations in population. And that's a consideration that I don't think we've really discussed. So thank you for bringing that point up. Thank you.
Thank you.